Welcome, everyone. Thank you for joining us for Region 11's monthly webinar series. My name is Erica Ricario Thorpe, and I am part of the Chapter Relations team at HFMA. To kick off the webinar, we would like to thank our sponsors, AmPlus, Commerce Healthcare, Progressive Management Systems, Parallon, Firm, TCF Capital Solutions, Harris & Harris, Extend Healthcare, Access One, HRG, AccuReg, Novus, Mail My Statements, Berlote, Premier, Centauri, TrueBridge, Avidyne Health, Patient Matters, Argos Health, RMC, Enable Comp, State, Sherlock, Aid Bailey, Softtech, OVAG International, and Vitalware. Your participation is required. There will be a live Q&A during the webinar, so put your questions in the Q&A pod. We'll also be utilizing the chat pod to share information and tips during sessions. And now it's my pleasure to introduce Wendy Wackbacher, past president for Northern California.
Hi, Erica. Thank you very much. Hi, everybody. This is Wendy Wackbacher. I'd like to introduce Jeff Burley, the CFO for Arizona Rural Hospitals, Banner Health. Mr. Burley joined Banner Health, then left Lutheran Health Systems in 1987 as a cost accountant. He was promoted to several positions, including finance manager, finance director, and was named finance administrator and CFO of the Lutheran Healthcare Network in 1998. In 2000, he was promoted to a corporate role as the System Director of Budget and Decision Support. In 2006, he was named the System Vice President of Planning and Decision Support. In 2009, Mr. Burley was promoted to the role of Vice President and CFO of the Arizona East Region. In 2015, he was promoted to the Vice President and Chief Financial Officer of Banner University Division through the acquisition of University of Arizona Health Network in Tucson. Currently, his role is the CFO of Banner Health's 5 Arizona rural hospitals. Jeff is approaching 30 years as a member of HFMA. He has served in all chapter and committee leadership roles over his tenure, including the role of Arizona chapter president for the 2018-2019 term. Please welcome Jeff Burley as our guest speaker for today.
Yes, good afternoon, everybody, and thank you for that introduction. I am going to be introducing our guest speaker. Unfortunately, it is not going to be Charlie Larson, our Senior Director of Banner Health Transfer Services. At the last minute, he had to be pulled away and unable to participate, and I'll introduce the Chief Medical Officer of Central Logic, Darren Versello, just in a few minutes. But I thought what I would do is start off maybe saying some of the things that Charlie Larson would say. I've known Charlie for many years, and you see on the screen kind of a snapshot of Banner Health and the work that a Banner Transfer Services must manage between all the locations across 7 states, 6 states, and most of the volume, about 85% of the volume coming in the Arizona market between Phoenix and Tucson. I mean, when Banner and Charlie started off in this effort, it was really trying to fill a gap where we had a $40 million revenue gap that was identified. We had prolonged transfer times. We were not only able to strain the physician satisfaction by and dealing with losses of greater than 500 people per month. You can tell how physicians would appreciate that. Through the leakage and inability to get them to the system that of Banner, which they were choosing care for, and we just couldn't get them into the system. So 500 patients a month, about a $40 million gap. Addressing the underlying problems meant that Banner was able to speed time to care, acquire new patients, and more profitably balance the patient levels within our health system. Coincidentally, COVID hit, and Banner Health was very tied in with the governor's office, with Arizona Department of Health Services, and we recognized that we couldn't let any one facility inside of Arizona get hammered with all the COVID patients or disproportionately admitted to a facility because we would overload that facility. Their staffing, their physicians would be the worst thing that we can do for our patients. So by working with ADHS and the governor's office, we were able to, through the technology that was put in, have a secondary benefit of running a surge line, an Arizona surge line. So when any patient presented wherever throughout the state, and it was a COVID positive or COVID pending, we would actually go through ADHS, it would go through Banner Transfer Services through our tools, and place the patient at the next facility that was due a patient. So we were doing this through Dignity, through Banner, through Tucson Medical Center, Flagstaff, all over the state. We were able to redistribute patients to meet the needs and load level the state for our COVID surge. So Banner played a significant role, particularly in June, July, August, where we had our second wave, in making sure that the state didn't get overloaded or any one facility didn't get overloaded. So to tell you a little bit about the mechanics and the story behind it, the Chief Medical Officer, Darren Vercello, co-founded CentralLogic, drawing on his experience in developing and implementing medical information systems specifically designed to manage complex patient needs, medical education, and faculty and staff logistics. He is a board-certified hospitalist practicing in the Salt Lake City area. Darren also served as a clinical advisor and technical developer at the University of Utah Health Science Center. Previous to his role at CentralLogic, Darren served as a physician knowledge engineer and interim chief medical officer at Theradoc. So please help me welcome Dr. Darren Vercello to help us with the rest of the webinar.
Thank you, Jeff. I appreciate that. It's a pleasure to be with you all today, and thank you for taking your time. We'll keep this interesting for you and hopefully geared very much towards the work that you do in your organizations, especially around the business and finance of healthcare. Of course, we always know that the clinical care and the quality of that are of utmost importance, and so we'll keep that focus around. I think Jeff's introduction, including the Arizona surge line, is very significant. Having seen Arizona get hit with such a huge load of patients that were positive for COVID-19, rivaled what we saw on the East Coast, up in Washington. Fortunately, many other states have not had to weather that storm and bear that burden, but the actions that the governor took and the state took to centralize that capability and have a great state-run venture there to keep the citizens of the state of Arizona balanced across all the hospital systems, especially those coming in from the deep rural areas, from Indian Health Services, from the border towns, was of tremendous help, both from a clinical standpoint, but also from a fiscal standpoint, because they didn't have to open up very expensive alternative care sites. And so it's been a great effort. It's been something that I've enjoyed watching unfold. So today we're going to talk about the Banner story, though, and a great story it is. I've had the pleasure of working with Banner now for 2 years on this project and see it come through various phases of implementation and success. And I'd like to take you through those today, hopefully with the same efficacy that you would have if Charlie were here. And we'll talk a little bit about Charlie's leadership as well as his boss, Dr. Jason Brown, who really spearheaded this project with Charlie. Just a little bit, first of all, about Banner Health as we've worked with them. Their transfer center, Banner Health Transfer Services, has long been established, and it's been a real staple in the medical community there. Over 10 years of consistent work, 24/7, handling more than 3,000 patient transfers a month. So from the CentralLogic side, and I know many of you on the call may not be aware of who CentralLogic is, or maybe you've had some dealings with us. We are a transfer center and access center software and services company. We're based out of Salt Lake City. We work with about 600 hospitals across the country, Banner being part of that clientele. And we bring expertise as well as software and processes, consultancies, as well as operations personnel to the table to manage exactly what the Banner Health Transfer Services team was looking to address. And so Banner brought us in after running an extensive RFP and search for partners in this space. And we were very grateful and honored to be chosen by Banner to work with them over these years. So as I was saying, very robust transfer center, doing a lot of work, staffed by nurses, which is a national best practice, and truly an integral part of Banner Health's operations. Now, what Jeff mentioned was absolutely true. As Dr. Brown and as Charlie and others were looking at Banner's transfer services, as many of you may have in your hospital systems, you may have transfer services that are addressing things such as bringing patients in from outside hospitals to get that patient care as quickly as possible and also bolster your revenues. This is a huge part of many hospital systems' revenue streams and bottom lines, to bring patients in that need trauma care, surgical care, strokes and heart attacks and other high acuity services. You bring them in from outside hospitals that aren't capable of taking care of those patients in those situations. And we'll talk shortly about the per patient contribution margin for those patients. Well, despite the fact that Banner was transferring 3,000 patients a month into the Banner system of 28 hospitals, they found that 3,600, and Jeff had mentioned 500, this actually climbed up to almost 680 patients lost per month. So over 3,600 requests for transfers were coming in on a monthly basis, and 600 to almost 700 of those were being lost because of the complexities and the functional problems that the transfer services were having. And this is something that Charlie will talk very, very clearly about, is that it was very challenging for them to understand where the problems were and where could they tune the system so they wouldn't lose these opportunities. As Jeff mentioned, this was a $40 million a year loss. Now, that was $40 million a year that they could track. From the CentralLogic side, we've worked with a lot of large organizations, HCA and Sutter and Banner and Mount Sinai and many others around the country. And, it's one thing to track 600 plus patients that you're getting called on, that ultimately those referring physicians are hanging up before you get the chance to say yes and bring that patient in. It's quite another thing to consider that there are still many, many more that aren't calling you because of previous bad experiences or word of mouth. And so, although there was a $40 million known loss on an annual basis, it's very likely that there was much, much more that wasn't known because of the perception out in the community. One of the ways that this was being tracked by Charlie was he was tracking growth year over year. And where in 2016, he saw that they had grown 13% in the numbers of patients that were coming in. The following year, it was only 7% in 2017. And by 2018, their growth had slowed to only 2%. And when we engaged together in 2019, they actually saw negative growth. So they were losing business out into the community. And this was a frustration. This was a frustration, obviously, to the leadership at Banner, that they were losing those opportunities, that the perception in the community was they weren't fulfilling the need, that many dollars that people were sending their way couldn't be captured. And so they really looked at the reasons why, and they were able to identify a couple. First of all, it was taking Banner over 3 hours to transfer a patient into their hospitals. Now, from the CentralLogic side, our national best practice standard is to get that from the time a physician calls and says, I want to transfer you a patient. This is Dr. Versillo. I've got a patient in my little hospital that has head trauma. I need to send my patient to you. From the time that call comes in to the time that you say, yes, we'll take the patient, that should be less than 15 minutes. And Banner was suffering this out at a 3-hour time. Now, this was because they were not aligned with their physician culture. They weren't able to find beds. There were a variety of reasons. And one of them was just a knowledge of what transfer center services did for the organization. As a matter of fact, as they asked around the organization, people would say, transfer, you mean like ordering an ambulance? So clearly there was a perceptual deficit. Additionally, there was a deficit or there was a problem with their organizational complexity. Banner has several large trauma centers. They have big groups of practicing physicians around the Phoenix area, Tucson, northern Arizona, up into Colorado, and many other states, as you saw in that first slide. And each of these organizations over the years had developed protocols that they used to interact with the transfer center. And you see over here this example of a quote-unquote simple protocol that's used for trauma. Lots of sidebars, lots of exceptions, lots of variations, and alternative pathways depending on which physician you were talking to or what region that this was coming from. So these overly complex protocols were driving some of the complexity and the amount of time that it was taking to get this done. Additionally, they had 4 major trauma services downtown in Phoenix, for example, that each had their own protocols. So it was very difficult for the transfer center nurses to stay on top of the needs of each of these different organizations and stay expert on them. So they came to the conclusion, and rightfully so, that there had to be a better way. And so Dr. Brown, Jason Brown, who is the Chief Medical Officer over Transfer Services and Pharmacy as well, alongside with Charlie Larson, who is the director of the Transfer Center, a nurse by training, and also very adept in both the management and business aspects of healthcare management. They got together and went out and interviewed. They worked with leadership, and they looked at what needed to be done and what were the opportunities and the problems and the struggles that were being faced, and came up with this 45-page document addressing all of the issues that they found within Banner. And this explained everything from as Jeff mentioned, identifying the $40 million loss, identifying the delays in clinical care, which were obviously not good for patients, certainly not good for the providers taking care of them, but also might have been putting Banner at legal risk as well. They identified other national best practice standards that Banner just wasn't measuring up to, and said, you know what, there's a huge cost to us for not doing anything here and just staying with what we've been doing in the past. And we need to forge ahead and find a better way of doing this. Even if there's some unknown to this, anything could be better than the current status quo. Well, there are a lot of reasons why we at CentralLogic see organizations changing their transfer services. Again, Banner has had this running for a decade or more. Sometimes CentralLogic is brought into a situation where that's the case, that this is not new. Sometimes we're asked by hospital systems to come in and create de novo, a new transfer center that's never existed before, or to provide transfer center services. But in the case of Banner, they were looking at their existing services, and they identified 7 points of areas where they wanted to improve, or reasons they wanted to improve their transfer center. First of all, patient care quality. And I really have to hand it to Dr. Brown and to Charlie for making this personal. As they went out with that 45-page document, they surrounded this entire idea around a persona, a fictional character that they called Little Sophia. And they were able to show all those that they spoke with, that they interviewed, and ultimately that they rallied around, that this was going to make a difference in the life of a little girl who needed to be transferred for the illness that she had, and brought to Banner Health to get the best quality service that could be provided. And that was the great thing about it, is truly Banner Health provides great services. So this is about access, creating accessibility to care for little Sophia, for her parents and family, for the providers who want to see her get the care she needs. So patient care quality was the rally call from the very beginning, but it was brought to bear and certainly resonated with the leadership that they worked with when they brought in many of the other things that are important to those particular leaders, like yourselves, for instance, the financial benefits. What is the ROI? Is this going to be a cost center, or is this going to be a revenue center? Ideally, a profit center for our organization. What is the community perception? The COOs and the CEOs and those reaching out to the community to understand, how do people think about Banner, and what is the positive impact that a restructuring and an improvement in transfer services would have on community perception? A huge part of business. Next were the providers themselves, both the referring, those sending providers that are or are not sending us opportunities to take care of their patients, and even the internal providers, the accepting providers, the neurosurgeons, the trauma surgeons, the critical care doctors, the hospitalists, the ER doctors, that on the Banner side were saying, you know what, this is frustrating for us. How can we improve this? Banner certainly had a strong cultural need to move towards more systemness, to bring all of the Banner hospitals under a standard where all could be worked together. Like we talked about, those protocols were just a symptom of a much larger issue that needed to be overcome, which was siloed people working in lots of different areas with different workflows and different protocols. They wanted to overcome that. And then finally, they identified, and rightfully so, that the Phoenix area is quite a competitive landscape. As Jeff mentioned earlier, there are many hospital systems, Tenet and Honor and Dignity and Steward and many others who are vying for that business. And so Banner had to put their best foot forward to stay competitive in that landscape. Well, as they met with these organizations, they realized right off the bat that even though they could identify that there were problems, they needed to be able to quantify them. And I know many of you who are on this call, you're data people, you're numbers people. And Charlie has a great saying that he likes to bring up at this point, is you just can't bring feelings to a fact fight. And he was getting questioned over and over again. Quantify the issue for us. What's the data? Show us the data. And what they realized right away was they couldn't. Because of the way that they were managing their transfer center, using their a medical record system to document when transfers were made, they were not able to draw the data out appropriately and show how long it took to get those transfers done, who they were contacting and were saying no, what the protocols were that they were using and whether or not those were working, and so on and so forth, because so much of the data that was being entered into the system when transfers were happening was being entered in as free text. There was no structured way to go through a transfer from start to finish and get that in discrete data points with data labels and with time slices and be able to track all of that. So they needed better data. Additionally, they realized that they needed to engage and enlist the help of leaders across the organization. It's one thing to come up with an idea at the level of the transfer center, but they needed to elevate that to be something that leadership across the organization could really wrap their arms around. The medical directors, the chief medical officers, nursing and other clinical leadership, the executive leadership at all levels. And they were able to do this through some close engagement with these leaders and really finding out what was important to them. And then ultimately, they realized that they couldn't do this alone and they needed a strong operations partner. So they went out to RFP and they looked at many of the systems that they were already using within the Banner organization, which included Cerner, and they had some bed management partners and Philips and GE, and also they looked at CentralLogic in their search, finding that we specialized in transfer centers. And just to quote Charlie in what he says about their search and ultimately their decision that they looked at these various organizations. And again, we were very honored that they selected us. And he said that head and shoulders above all of these others was CentralLogic. And he said, quote, "And that's because CentralLogic focuses on transfer centers. That's all they do." And we knew that they came to the table with an understanding and that they knew the challenges, what the challenges were, and they were engaged with us, whereas some of the other organizations that they looked at only had a piece of what he said, quote, "what we needed." So we were selected to work with them, and we formed a partnership early on. And for those of you who obviously are very involved in contracting with partners and vendors, CentralLogic did a full assessment of Banner Health and where they stood. And our contracting with Banner, between CentralLogic and Banner, was proposed as an at-risk contract, where we would come to the table with technology, with additional leaders and leadership to partner there, with the workflow design, with a full provider engagement program, and that we would guarantee a certain amount of growth over a period of time, and that a percentage of our contract would be at risk based on achieving that growth. We're able to do that because we know what financial impact each transfer has. A few years back, we commissioned the University of Utah Eccles School of Business to do a sweeping study across the nation to understand the financial contribution of a transferred patient. And what we found is that it varies from state to state. It also varies regionally within states, but that the national average contribution margin, this is not the revenue, but this is the true contribution across the 50 states, is $10,800 per transferred patient. Now, you may say to yourself, well, I know what the contribution margin of my patients is that come into my hospital, and that seems high. Well, one thing you do have to remember is largely these transferred patients are high acuity patients. Trauma, stroke, interventions requiring procedures, patients going into ICUs with septic shock. They're being transferred for a reason. And so they are high dollar, high margin patients because largely they're coming in with these procedures. So you can imagine losing the opportunities on 600 plus patients a month at these dollar values was quite an eye-opener from a financial perspective. When CentralLogic comes to the table, we address all of those issues that Banner Health had identified that they needed to manage. Some were clinical, some were financial, some were cultural aspects of how the physicians were interacting with the transfer center. Some were operational issues right within the transfer center itself. And so we leveraged the best practices, again, after doing this for a decade and a half with 600 plus hospitals across the country, ranging anywhere from a small hospital like Billings Clinic in Billings, Montana, which is an individual hospital taking transfers in from the whole Northwest region, to large chains and large regional hospital systems like Banner Health. Or others in the western states and New York City, across the country, that are looking to address these issues. And over the years, we've gathered these best practices in so we can address all of these issues from financial to clinical to legal compliance, so on and so forth. As we looked at this with Charlie, again, Charlie was able to go back then to his constituents there and address some of the questions that they had. Well, of course, as they talked about the clinical needs, nobody argued the fact that getting a bed for a patient in need at the right time and getting the best care was ever a bad thing. So the clinical discussion oftentimes was a foregone conclusion. If we can provide better care through Banner Health Transfer Services, absolutely, let's do that. But when they were able to then come to the table and say, this is the financial impact that this is going to have for our organization. Initially, as they looked at their contribution margin for transferred patients, they were tracking that at about $5,500 per transfer patient contribution margin. They've since uplifted that as they've been able to identify more clearly where those patients are coming from and what sorts of services they're receiving. But ultimately, Charlie was able to look at what their break-even point would be on the contract that they had with CentralLogic. And their year one contracting was paid off in 31 days. So there's your 1 month for a whole year return on investment. And actually, they broke even on the full 3-year contract half a year into the project. So this is a tremendous financial ROI in bringing dollars through the door that makes it kind of a no-brainer to make the decision to take the plunge. And then last but not least, on an operational basis, they hit point after point after point of areas with providers and nursing and leaders to make sure that the transfer services was operationally addressing the needs that were frustrating so many people. So just in review then, the opportunities and the areas that were addressed to create the Banner Health Transfer Services success included, first of all, leadership engagement. Dr. Brown and Charlie went out and interacted with the CMOs and the CEOs of the individual hospitals of the corporate level as well. They engaged with the leaders in the different service lines, such as trauma, hospitalist, infectious diseases, critical care, so on and so forth. So they all had a voice and transparency into the process. They looked internally at transfer center operations with CentralLogic as a partner, and we identified that the complexity that they were using in the transfer center was causing delays, and we went for a streamlined internal operations within the transfer center. We managed to look at system-wide standardization and made that a priority goal for the relationship between CentralLogic and Banner. And this included standardization of protocols, those numerous trauma protocols, for instance, in the Phoenix area, consolidated all down to one in a much more streamlined format. And we also addressed the very culture of physician interaction with the transfer center, helping them to get to what we call a single provider acceptance model, which allowed them to contact one physician who was on call, get a yes from that physician, and immediately get back to the referring physician and say, yes, we'll take that patient. Well, when you consider of those 680 physicians per month that were hanging up, they were able to track that 60 minutes out is largely when a lot of those physicians started hanging up on them. 30 minutes out, they already had about 50% of those physicians already hanging up. But at 10 to 15 minutes out, they were still on the line. And having put into play now a physician culture change, as well as streamlined intake and some better bed visibility and data visibility, Banner is tracking well under 27 minutes for transfer center acceptance, and has been able to keep now the vast majority of all of those patients they were formerly losing. So how have they been able to do that from a technology standpoint? Well, one of the things put in place was a system-wide capacity visibility board. This provides, at a glance, real-time visibility of all of the beds across the system that they can make the choice to place a potential patient. CentralLogic does this by taking in data feeds from multiple systems. To the point that Jeff made, we've also implemented this at the statewide level. So not only are we taking data in from multiple places within Banner, but from other systems across Arizona to provide that visibility for the state as well. This allowed Banner to shave over an hour off the transfer process time by being able to identify those hospitals with the level of care that they needed that were in the green and ready to take a patient instantaneously through live data. Otherwise, they found themselves having to call the charge nurses and nursing supervisors at these different hospitals to ask, do you have a bed? And always questioning whether or not they were getting accurate information. Now they have it real time. This also allows Banner to load balance patients across the system when we talk about systemness within an organization, being able to not only take a transfer into a major trauma center inside the Phoenix metro area, but potentially to be able to transfer that patient from a rural hospital to a regional medical center that provides those same services and maybe an hour closer to where the patient and their family live, allows Banner to spread their brand across their organization and leverage those hospitals and not send every patient to the main hospital. Two main effects from that. One, it expedites the transfer time, but two, it also allows them to have a positive impact on the case mix index at both hospitals. In your regional hospital, to raise the case mix index based on the fact that they're taking higher acuity patients there, and in the main trauma center, raises their case mix index because they're not taking lower acuity patients from the outlying hospitals as well. Positive impact all the way around. Mentioned before as well, and this is an area that Charlie would definitely spend time emphasizing, was what they called PIPs within their organization, or what CentralLogic calls the Provider Engagement Program. PIPs within Banner was to get to that coveted single provider acceptance model, or SPA model. So when a sending physician calls in and says, I need to send you a patient, they can immediately identify who's on call and ready to take that patient. Now, from the financial aspect, one, that makes the transfer center tremendously more efficient. They can handle many more calls with fewer FTEs, simply because they can get to the right physician initially and not have to call multiple hospitals and take more time to do that. So it created efficiencies within the transfer center, but it also created a speed to yes decision, giving a white glove experience to the sending physicians that were referring providers. This was a tremendous and sweeping program throughout the organization, one that I led myself in conjunction with Dr. Brown, in meeting personally with the leaders of the trauma teams, surgery, as I mentioned before, hospitalists, many of the subspecialties, also meeting with engaged leaders at the corporate level, their system CMOs and directors. By doing this direct engagement, we were able to successfully roll out the Provider Engagement Program in early August of this year, after doing a test at one of their major medical centers. And we've dropped the physician decision-making time down from an average of 15 minutes to around 15 minutes now. And it's having a huge impact on patient care and being able to capture those opportunities and bring the high-paying patients through the door. We also know that this is having a tremendous impact on the community and those physicians that are referring patients. Word is getting out, and the physicians are referring more patients on a secondary and tertiary basis, and more physicians that weren't referring patients before are now returning their business to Banner. What we see here on the screen is an example of just a booklet or part of the training guide or onboarding guide that we leverage as we meet with physicians, and we bring them up to speed on how this program works and align them with the transfer center. Banner did some wonderful additional work in taking this content and putting it into a Sway environment, a web-based educational tool that allowed their providers to go and see exactly what the transfer center was offering them and be transparent about the work that they would do together as transfer center and accepting physicians. Over here, we see what we call the SPA matrix, or the single provider acceptance matrix. This is a guide tailored to the Banner organization that diagnosis by diagnosis tells the transfer center who their point physician is to go after and page them. Now, I know that many of you have on-call covenants with your physicians, fee for call or fee for coverage, and this created tremendous transparency around those who were living up to those covenants that we're paying them for to take unassigned call and take patients in and transfer. And so between the on-call scheduling system embedded within CentralLogic and then the reporting capabilities, we were able to generate these dashboards. And I know the numbers are very, very small, but we're able to see things like, what's the cycle time that it takes to get a physician to be involved and say yes. How often are we calling them? What service lines are being asked for? So we can leverage that data to know, are our physicians being effective in living up to those contracts that we're putting in front of them? The process review that Banner has engaged in, I think, has been absolutely tremendous. They have a data analyst named Aaron who goes through their data. Largely, these are dashboards that are prefabricated within the CentralLogic system, and they do roadshows where they go out and they meet with the different regions and they show them just how well they're doing. And they bring to them dashboards that show everything from the productivity to the business requests to the payer mix and case mix index that's being brought in there. So, for example, showing them the insurance dashboard. It's a belief among some physicians that all transfers are dumps, that these are being transferred to them simply because nobody else wants to take care of them, and they have poor insurance and nothing left in their contract to compensate them. Well, truly nothing could be further from the truth. But again, you can't bring feelings to a fact fight, as Charlie says. By bringing the insurance dashboard to these providers, Banner has been able to clearly show them that the payer mix coming through the transfer center is equal to, if not better than, what's coming through the emergency department. So they truly are bringing good business to these providers and those that they're going to be compensated for. As we looked at the transfer times and the interventions that were taken, now there's some spikes in here, definitely, as Jeff had mentioned before, when the COVID pandemic hit Arizona really badly, that shot up some of the times taken to make these transfers happen. But as Banner had put in place some of the efficiencies that CentralLogic and Banner Transfer Service has identified to improve their operations, and I'll name three. One is the streamlined intake process within the transfer center. The nurses in the transfer center were taking sometimes 35 to 45 minutes just interviewing the sending physician about data, far, far longer than needed to happen. And actually, in some cases, that was actually putting Banner at risk, at increased legal risk, because they were asking the nurses to do some things outside of their scope of license. So by scoping that down to where the nurses should be in a streamlined intake, by creating that real-time bed visibility that I showed before, and by implementing the single provider acceptance or PIPS program, you can see how Banner has gotten these transfer times in a decreasing amount of time over these ensuing weeks to months, and that continues to go down now into the late August and into September, now below 30 minutes for their average acceptance time. Absolutely tremendous turnaround in their capability to say yes and get those patients through the door. They bring these dashboards, like I mentioned before, and they're able to compare the service lines. Physicians are very competitive people by nature. And so if you show them that the internists are outperforming the surgeons, or the general surgeons are outperforming the neurosurgeons, and so on and so forth, that competitive interest actually can change physician behavior as well. If nothing more, again, bringing facts to the table allows you to sit down and have those crucial conversations, and in these particular reports, drill down to the actual physicians that might be causing the cardiology group to be 30 minutes above where everybody else is. Maybe it's not the whole group. Maybe it's one or two physicians that are performing poorly that we can educate and help to improve. Well, like I say, the improvements have been dramatic. The decrease in the amount of time it takes to transfer a patient is clearly evident through the data that comes out of the system. They have gone from, in 2019, a loss of 700 less patients accepted in transfer than the year before, to 2020, over 3,000 more patients accepted than the prior year. So clearly this has been tremendously successful, and goes well into the millions of their turnaround just in the first few months of going live with this. So they're being they're being very, very successful with this. And they've also been able to create some dashboards or provide dashboards for senior leadership in those areas that they're most interested: cycle times, denials or acceptances, regional referral patterns. And they're able to set these data points as thresholds. Are we underperforming in areas? Where are we overperforming and doing very, very well? So in these stewardship dashboards, and how long it takes to accept, and when decisions are being made, how often are transfer requests canceled, when are we declining and turning away business, they can easily visualize that and take action to modify protocols as needed. So again, just additional dashboards that look at the business of running a transfer center. We love this one called the REAL analysis, which stands for, REAL is an acronym, which stands for retention, enablement, acquisition, and leakage. Are we keeping patients within the organization when they're there? Banner, like many of you, is an ACO and has at-risk patients that they're paying for. So understanding whether or not we're retaining patients within the organization or having to pay our competitors to take care of them is a big, big deal there. So we can see that clearly and understand the role that the transfer center plays in that. So just to wrap this up, this has been fantastically successful for Banner. They've been able to engage with leadership that have clear visibility into the data that's being generated by the system. They've been able to engage with referring and accepting physicians and get the flywheel of that business turning and get those patients coming through the door and keep the providers very, very satisfied, much more satisfied than they have been in the past, and to get the feedback, especially from some of these physicians who interact with multiple systems in the area, that Banner now ranks at the top of their list for satisfaction of transfers as opposed to the bottom of their list, which has been a tremendous turnaround. And so as they look at the success within Banner, now they're looking at what more can we do with our transfer services. They are looking at what they call their command center concept, or what CentralLogic will also often refer to as an access center concept. Can we not only transfer patients in, but can we move them out and place them in skilled nursing facilities? Can we load balance across our hospitals with transfer back agreements? Can we do direct admissions from physician offices? And can we even manage some of the ambulatory needs or ambulatory referral needs to capture surgical patients that are our opportunities? This has really led to an ongoing and growing vision for what Banner Health Transfer Services, which may very well someday be renamed as Banner Health Access Services, to provide for the organization and the states where they exist. We've talked about this idea of load leveling and improving contribution margin, taking care of patients at hospitals that perhaps don't have as high of a cost profile as some of the larger level 1 trauma centers, and this idea of repatriatization as well, of making sure that their patients that they are at risk for stay within their organization and don't end up in a competitor's hospital being taken care of for days on end when Banner doesn't know about it, making that the business of the transfer center to transfer in those patients and make sure that they stay within Banner's services. So the work will go on. Very excited to continue to work with Dr. Brown and with Charlie to see their energy and their vision to work with the leadership throughout Banner, especially as they recognize the ongoing contribution that the transfer center is making to their organization. And really excited, quite frankly, also to see the standard that Banner is setting for many other organizations throughout the country, so they can look and see how greatness is achieved and the impact that it has. So with that being said, we'll turn it back to the group. If there are any questions you'd like to ask, we'd be happy to do a Q&A.
Darren, we've had a couple questions come in, but before I read them, I'll just remind the group that if you have additional questions, please post them in the Q&A. There's a little link at the bottom. And the two that came in weren't specifically directed at you or Jeff, so I don't know how you'd like to answer them, maybe together. and they may be related. So one is, what are the key metrics to look at? And the other one is, for an organization that does see this as a cost center, how do you best make the business case to put something like this in place?
Certainly. Jeff, would you like to answer either of those questions? I'd be happy to. And actually, I know Jeff had a hard stop. I'm hoping he's still here.
I'm still here.
There he is. There he is.
Yeah, I'm sorry. Would you repeat those questions? I'm sorry, and I'm happy to co-address them with you. That'd be great.
Sure.
Sure. One of them was just about the key metrics to look at and what the
Right.
executives at Banner are looking at. And then also for an organization that's seeing this as a cost center, how to best make the business case to implement something like this.
Right, right. So maybe I'll take the first one and maybe touch on the second one just briefly. The key metrics, at least we were measuring from the facility perspective to help Charlie accomplish this work, was our own accountability that we were going to just say yes. And how long was it going to be before, or how long did it take us to just say yes? So working with our hospitalists, working with our internal medicine physicians, whatever specialists that might look like, when a patient gets ready to present, if you have a bed available, we expect you to say yes. And let's get this transfer time under 30 minutes. So we were measured, and in our stewardship, monthly stewardship with our corporate leaders, we would look at our results for each of the facilities and how successful we were in helping Charlie and the team accomplish what we were looking at. Obviously, Charlie was looking at many, many more different metrics from physicians and everything that would help us identify this physician might be a little slower, but overall, here's how the impact is on your facility. So that's the input that I can share with you as far as what I looked at. I did help Charlie a little bit, not particularly on this project, but early on in just doing transfer services. And what I look at as a CFO is, do we have an ROI? If we're going to put effort into, and particularly nurses in this effort, which is the best practice, an expensive best practice, but it's still the right thing to do. If we're going to have nurses in this work and not on the floor working with our patients, we have to make sure it's the best we can have, best we can be for the money that we're paying. And at $40 million just of loss, so that if you think about we only losing 600 of the 3,600, so you can see what the total pie looks like for bringing patients into Banner, multiple of 6, then we were able to demonstrate here's the cost of setting up a transfer service and here's the benefit of it. And now we've taken it with Central Logic and able to measure all of this and say, now beyond what the transfer services team can do, we're going to measure our facilities and make sure that they live up to what they're supposed to be doing. So it's become full circle, and why on a second time it was made sense now to invest in a platform that helps Charlie and his team do their job better. And you saw 30, I think it was 31 days and 151 days, 3-year contract paid off. Those are the types of metrics that I know I look at from a CFO perspective to see if it made sense to stand on its own.
I'm not sure I could add anything to what Jeff just said. I think he hit the nail on the head. And I guess maybe the only thing that I would add, other than echoing what he just said, with both ROI and being able to see what those, how clearly those metrics tell the story, is that as we look across the landscape of the hospital systems that we work with across the country, we're able to see some kind of standard outcomes with respect to this, whether it's a 15-to-1 ROI or a 20-to-1 ROI on dollars invested to dollars that come through the door. And that, quite frankly, is one of the great things about transfer centers is, although all projects have value, there are projects that create efficiencies and save money. There are projects that are geared towards protecting revenue against things like compliance issues or recapture. The great thing about transfer centers is this is, apart from great patient care, this is all about bringing more people through the door, and the right type of cases too, if you're targeting certain service lines. So, so being able to quantify the effect that it's going to have, we look roughly at systems and we say, okay, you have you have 500 beds in hospitals that could be accepting hospitals for patients coming outside of your system. We should have about 500 patients per month coming through the transfer center occupying those beds. And so if we look at what you're currently doing with somebody who's just having a phone, or maybe a transfer center that hasn't been optimized, and you only have 150 patients per month that are being transferred, there's an enormous amount of opportunity that we can predict, that we can project and forecast. And then based on the dollar values of what your particular state or region generally has as a contribution margin for those patients, we can quickly start to quantify what that ROI is going to look like. And as I mentioned before, we're so confident about it, as we've seen with the success with Banner, we're willing to take the risk on that as well, because we know it'll be a success. I know we're at the end of time, but one of those questions are, what were the metrics that are looked at? There are a lot of different metrics, but the participation, as Jeff mentioned, in the responsiveness by physicians, the numbers of patients that are coming through, where those referrals are coming from regionally, and specific service lines that are being targeted. If you have a transfer center that's seen as a cost center, it's likely, one, it's either not understood, the contribution that's being made there, or two, it's just not being leveraged the way that it should be. So one of the things that we can do is come in and do an assessment and help that be understood. In some cases, it's just it's also affected by the way that fixed and variable costs are being assigned. So we'd love to sit down and have that discussion and help with any of those assessments as necessary. Thanks, Robert. Sounds like that might be it for the questions.
That's all the questions.
Okay. I guess we can turn it back over to Wendy.
Yep. Hi, everybody. This is Wendy Weckbacher again. I just wanted to say thank you very, very much to our guest speakers for all of the efforts that they have put into this, and to give us this great information and educational opportunity. And thank you, everyone, for joining us today. We hope that you got some great information out of it. And I will turn it over to Erica to close it out with our sponsors.
We just want to say a huge thank you again to our sponsors, and thank you all for joining. We appreciate your time. Thank you to our speakers, and thank you to Region 11 for putting this on. Thank you all again. Have a great night.
Thank you, everybody.